Good morning, good morning, and welcome to another session brought to you by your Department of Continuing Medical Education. I am so excited to have all of you here this morning, and I am so pleased to see so many of you here so early this morning. And you have caught our first early bird special. You have always heard the saying, the early bird catches all of the worms. And you have caught all of the wonderful nuggets in the questions and answers this morning. So before we begin, let us do as we usually do by starting with a word of prayer. Father God in heaven, we come before you this morning, thanking you so much for this another wonderful day, another wonderful opportunity to learn with each other. There are so many people who are out there who are hurting, who are in pain, who are sick. And you have given us the ability, oh God, to play a small part in their healing, in their management. And we do not ever want to take that for granted. We pray that you keep us forever humble. We pray that you will always strengthen us, that we will do the best of our abilities. Be with the speaker as he presents today. This I pray in Jesus' name. Amen. So this morning, we have a wonderful presentation for you. And one of the big part about CME is ensuring that we are keeping up to date with the most current information. That is evidence-based practices. And in doing that, we ensure that we are bringing the very best to our patients. So today, providing our education is none other than our very own Dr. Parker. For those of you who may not know Dr. Parker, I will introduce him to you. Dr. K. Neil Parker is a graduate of the University of the West Indies, Mona campus. He completed residency and fellowship at SUNY Downstate, Brooklyn, New York, and is board certified in internal medicine and rheumatology. He is a consultant in the Department of Internal Medicine at the Princess Margaret Hospital in Nassau, Bahamas, where he directs the rheumatology clinic and consultation services. Today, Dr. Parker would be presenting to us on updates in the management of lupus nephritis. Welcome, Dr. Parker. While we sort out some technical difficulties, I just want to remind everyone to please ensure that you are signed in with your name that you use with the Bahamas Medical Council. This is a accredited CME session, and we don't want you to miss out on your CME points. So please take this time and ensure that you are signed in with your full name We should be starting momentarily.
Audio's on. Or, oh, okay.
Okay, thank you so much for your patience. And I see we've had an opportunity to welcome a few more people to the meeting while we waited. So lucky for you this morning, you didn't get to miss any of the wonderful information that will be coming towards you today. So good things come to those that wait. And right now, we will begin our presentation on updates in the management of lupus nephritis, brought to you by Dr. Parker. Dr. Parker?
Yes, good morning, everybody. Sorry for the late start. Okay, so updates in the management of lupus nephritis. Lupus is a condition that we see quite a bit in the hospital, and we take care of a lot of patients with lupus nephritis. And I'm sure many of us feel like we have a good handle on the condition, but of late there have been some updates in the management, mainly due to progress in the field and approval of new medication. I'm just trying to move the slide along. Hold on. Okay, I guess that'll do it. So we're going to review the pathophysiology of lupus nephritis, understand the various classes, and then the approach to the management of those classes of lupus nephritis. So about 35% of adults with SLE have evidence of nephritis at the time of diagnosis, with 50 to 60% of those patients going on to develop renal disease within the first 10 years if they're not diagnosed at the time. The prevalence of nephritis is higher among Blacks and Hispanic women, and higher among men than among women. Ironically, when men get the disease, it's more severe. So we define renal involvement of SLE still according to the 1997 criteria, that is to say, proteinuria of greater than 1 gram or greater than 3 plus on a dipstick, or a spot urine creatinine ratio of greater than 0.5. Cellular casts in the urine, including red blood cell casts, hemoglobin casts, granular casts, or tubular or mixed casts. However, as a practical consideration, the casts usually dissolve by the time the urine is transported to the lab. So realistically, we're looking at proteinuria and hematuria clinically as the major determinants of lupus nephritis, with the ultimate diagnosis being made by kidney biopsy, which is a challenge given the resources or the resource strain we are under nationally and as a system. The indications for renal biopsy include serum creatinine without a compelling diagnosis or without a compelling alternative diagnosis, confirmed proteinuria of 1 gram per 24 hours on spot urine creatinine, spot urine protein or creatinine, or combinations of 0.5 grams, as well as red blood cells per high-powered field, which can indicate an active sediment, that is to say, inflammation within the kidney, or proteinuria and cellular casts. Lupus nephritis is classified by the International Society of Nephrology and Renal Pathology Societies into 6 classes. Class 1 is minimal mesangial lupus nephritis. Class 2 would be mesangial lupus nephritis. Class 3 would be focal lupus nephritis involving less than 50% of the glomeruli, with um, other classifications determining whether how active the lesions are or chronic, depending on the amount of sclerosis and scarring. Class 4, which is the most common and the most aggressive type of lupus nephritis, is called diffuse lupus nephritis, where greater than 50% of the glomeruli are involved, again with further subclassification into chronicity, active and chronic lesions, depending on the extent of the sclerosis. This obviously can only be determined on the kidney biopsy. And then you also have global and segmental in terms of how much of the tufts are involved in the various different glomeruli. Then there's class 5 or bland lupus nephritis, where you have membranous disease. This typically doesn't involve any hematuria, just proteinuria. And class 6, which is advanced sclerosing lupus nephritis, where you have globally sclerosed glomeruli without residual activity. Just a basic schema of the glomeruli, showing the basement membrane as well as the capillaries, and then the mesangium at the center. The bottom line is when the basement membrane and the capillaries are involved, you get active lupus nephritis 3 and 4, 3 to 5, where that's the most serious disease with the highest risk of progression to kidney failure, with the mesangial involvement being less of a clinical problem. The pathophysiology is non-specific activation of autoreactive B cells, producing a polyclonal antibody response. With the diagnostic hallmark of lupus nephritis is the quote-unquote full house pattern on immunofluorescence, when you have involvement of IgM, IgA, and IgG deposits. B cells have pathogenic effects beyond antibody production and autoantigen presentation to activate autoreactive T cells, as well as there are local pro-inflammatory effects. Immune complexes deposit in the mesangium in class 1 and 2, in the subendothelial space in class 3 and 4, and in the subepithelial space in class 5, that is on either side of the basement of the endothelial membrane, either away from or towards the basement membrane of the glomeruli. And you can also have peritubular capillary involvement. Glomerular complexes can form in situ and have binding secondary to nucleosomes from renal cells or from neutrophils. So we can get complexes depositing from systemic circulation as well as from local deposition of the antibodies. Infrarenal immune complexes produce result in active complements, and the complement has a dual role in lupus nephritis. The deficiency impairs opsonization and removal of lupus autoantigens from the extracellular space, and complement factors also directly mediate immune complex-related renal inflammation and immunopathology. The nucleic acid component of immune complexes activates intrarenal inflammation and the intrarenal macrophages and dendritic cells. You get stimulation of the mesangial cells and macrophages by large amounts of pro-inflammatory cytokines, cytotoxic T cell production, including Th17 cells and B cells. So minimal mesangial lupus nephritis, these patients only have mesangial immune deposits. They're identified by immunofluorescence on electron microscopy. There is no light microscopic changes, and it's the earliest and the mildest form. Typically, patients have a normal urinalysis, a minimal or no proteinuria, and is rarely diagnosed clinically. And this is a light microscopy of patients with class 1 disease. You just see at the center of the glomeruli, the darkening of the stain. We are unable to, our problem locally is that this is the level of pathology that we are able to do. However, it's not specific enough to give us the diagnosis that we need to make to distinguish the various classes, or even determine that the primary pathology. What we need would be the immunofluorescence and the subsequent electron microscopy. The second class is mesangial proliferative lupus nephritis. The light microscopy reveals again mesangial hypercellularity. Immunofluorescence and electron microscopy reveal isolated subepithelial and subendothelial deposits. You can get podocyte effacement with nephrotic syndrome. Patients typically have microscopic hematuria and proteinuria, but hypertension is uncommon. The renal prognosis is excellent, and immunosuppressive treatment is rarely needed. And here again, you see the proliferation more towards the center, away from, but you can get some endothelial involvement. And then you would have the immunofluorescent pictures demonstrating the location of the deposits. Now, class 3 and class 4 are the more serious and clinically significant types of lupus nephritis. So focal lupus nephritis, the light microscopy reveals involvement of less than 50% of the glomeruli. That's why it's denoted as focal. However, immune fluorescence and electron microscopy reveal almost uniform involvement of the deposition of IgG and C3 and complement. Hence, the limitation of the light microscopy on the determination of the type, as well as the extent of pathology. And you can get segmental glomerular nephropathy where there's less than half the tuft involved, with subendothelial and mesangial immune deposition. Subclasses are based on activity, where you have focal proliferative versus chronicity, where you can have focal sclerosing. And the more sclerosis involved, the less reserve the patient has. And it tells you how likely the patient is to be able to recover, or how many more insults they can sustain. And you can even get to, how likely they are to progress to end-stage renal disease over time. Patients typically have hematuria, proteinuria, as well as hypertension, with reduced glomerular filtration rates and nephrotic syndrome. So you see the larger tufts. Again, with the light microscopy, it's not, it is more involved, but it doesn't reflect the full extent of the pathology. And then you have the more intense distribution of the deposits on electron microscopy. Diffuse lupus nephritis, or class 4 lupus nephritis, which is the most common and the most dangerous type of lupus nephritis in terms of renal prognosis. More than 50% of the glomeruli are involved in light microscopy. The lesions may be segmental in terms of less than 50% of the glomerulus involved, or global, where there's more than 80% of the glomeruli being involved. There are subendothelial deposits noted, and the subgroups are determined again as either global or segmental, as well as the potential for proliferative and sclerosing disease. Hematuria and proteinuria, which is often nephrotic, and hypertension, as well as reduced glomerular filtration rate, are common presentations. The anti-double-stranded DNA tends to be positive, and the complements tend to be low. As we stated before, it's the most common and the most severe form of lupus nephritis. And so you can see with the light microscopy, the involvement is more extensive, and the immunofluorescence reflects the same thing. Class 5 is membranous lupus nephritis, where there's diffuse thickening of the glomerular basement membrane on light microscopy, with immunofluorescence and electron microscopy revealing global or segmental subendothelial deposits, subepithelial deposits, sorry. So the primary difference between class 4 and class 5 is which side of the epithelial membrane the deposits form on. The mesangian involvement may be seen, and patients typically develop proteinuria within the nephrotic range. You may see microscopic hematuria, but generally speaking, there is a bland, we call it a bland urinalysis with no cells. The creatinine is usually normal. It can be elevated. The overall prognosis renally is better with class 5 than with class 4. And so you see the thick membrane, the thick glomerular basement membrane on light microscopy. And then the same thing plays out with the immunofluorescence. And then advanced sclerosing lupus nephritis. Global sclerosis of greater than 90% of the glomeruli and represents healing and old injury in advanced cases of lupus nephritis. This also is another reason for kidney biopsy. Many of the patients we see come in and we cannot tell based on the creatinine whether or not what is the prognosis of the glomeruli. In many of the patients who come in, based on the level of chronicity on the lesions and whether or not and the extent of the involvement, if these patients are in class 6 lupus nephritis, then it doesn't make sense to expose these patients to immunosuppression. And so this is one of the reasons we should be trying to pursue the capacity to do kidney biopsies, simply because many of the patients who present, and this is a common presentation of PMH and end-stage disease with lupus, whether they are new or old patients, we would be able to tell if we had a biopsy consistently in our clinical algorithm, whether it makes sense to pulse them routinely, exposing them to infection, complicating their course of dialysis, or whether we simply treat the end-stage renal disease and give them moderate to mild immunosuppression with antimalarials and treat their extrarenal disease. Patients tend to have a bland sediment with slowly progressive renal dysfunction. Immunosuppressive therapy is unlikely to be beneficial. So once you cross a certain threshold of kidney damage, regardless of the kidney function, end-stage renal disease is inevitable. And so you see the sclerotic lesion on light microscopy, as well as now tubular interstitial disease is another consideration, pathological more than clinical. It doesn't really figure into our clinical algorithms per se, and perhaps that is one of the reasons that sometimes our predictions about patients' prognosis renally is off, and that perhaps we underestimate the significance of the tubular interstitial disease, focusing more on the glomerular pathology. Lupus vasculopathy, immunoglobulins and complements containing thrombi within the capillary. And so essentially, another reason for kidney biopsies is that many patients can present with lupus nephritis. However, many patients who have lupus present with other types of lupus pathology, anything from minimal change disease of their children to focal segmental glomerulosclerosis to thrombotic microangiopathies, which we've also seen at this institution. And the treatment is entirely different in terms of whether or not you immunosuppress, whether or not you anticoagulate. So patients can have vasculopathy from multiple different pathologies, including antiphospholipid antibody syndromes or other primary conditions associated with autoimmune disease, or even mimicking lupus. The patients can evolve from one class to another, and sometimes repeat biopsies would even be indicated to guide our treatment. Kidney biopsy should be performed in patients with lupus involvement, with renal involvement, to determine the class and to determine the prognosis and guide the treatment. Patients with proteinuria of less than 500 milligrams in 24 hours and a bland sediment in the absence of worsening kidney function do not need a biopsy and are unlikely to have a lupus nephritis that warrants immunosuppressive therapy. Now, Reduction in proteinuria within the first 6 to 12 months from the start of treatment is the single best predictor of improved long-term outcomes in patients with lupus nephritis, in terms of reduced risk of disease flares, end-stage renal disease, and death. Due to the positive predictive value of proteinuria reduction in lupus nephritis, it has become an established objective and a reproducible endpoint for evaluating therapeutic interventions. And so we hone in on the proteinuria and the reduction of proteinuria more and more than other biomarkers in lupus nephritis. Consequently, lupus nephritis guidelines recommend evidence of at least a 25% reduction in proteinuria within 3 months, at least 50% of reduction by 6 months after, and at least 50% reduction by 6 months after initiating treatment, with a target proteinuria of 0.5 to 0.7 milligrams per milligram within the first year of treatment. However, with the conventional treatments in the guidelines up to 2012 and with the medications that we commonly use and we do have access to in our system, including the cyclophosphamide, the azathioprine, CellCept, and the rituximab, up to 60% of patients are unable to achieve these goals. And other therapeutic options have been sought and are continuing to be sought. And the reason I thought that it was so pertinent to present this topic today is because ultimately there have been some progress since the last publication in 2012 with respect to drugs that have been approved for use in lupus nephritis. There are two main medications that have been approved. We will discuss. One is voclosporin, which is a calcineurin inhibitor, similar to tacrolimus, and the other is Benlysta or belimumab. Now, the significance of it is that as of the last set of guidelines, I would have told you that even within our public system, we were able to access virtually everything a patient could possibly need to treat lupus nephritis. But with the advent of these new medications, given their cost, we run the risk of falling behind in terms of what is considered first line for patients with lupus nephritis, at least within the public system. So the first medication we're going to discuss is voclosporin. Voclosporin is a novel calcineurin inhibitor developed for the treatment of lupus nephritis. And it has several advantages compared to voclosporin and compared to tacrolimus and cyclosporin, which would be the traditional calcineurin inhibitors. These include a consistent pharmacokinetic profile, eliminating the need for therapeutic monitoring, a more favorable effect on the lipids and glucose concentrations compared with the other calcineurin inhibitors. Voclosporin, in combination with mycophenolate mofetil, compared to placebo, was found to rapidly reduce the voclosporin in combination with mycophenolate mofetil and rapidly lower dose of steroids when compared to placebo, was demonstrated to have a higher renal response rate. And so once this was done, they did what was called the Aurora 1 phase, or Aurora 1 trial, as opposed to the Aurora LV trial, where the efficacy and safety of voclosporin versus placebo for lupus nephritis was tested in a double trial, demonstrated in a double-blind randomized placebo-controlled trial. The primary endpoint for complete renal response at 52 weeks was achieved in significantly more patients in the voclosporin group than in the placebo group. You're talking about 41% more versus 23%. And this is voclosporin in combination with the standard of care, with mycophenolate mofetil. So voclosporin in combination with mycophenolate mofetil and low-dose steroids led to a clinically and statistically superior complete renal response rate versus mycophenolate alone with a comparable safety profile. So the significance of this study is that we have evidence now that um, whereas we could say first-line therapy is mycophenolate mofetil and you can achieve the best results possible, we now have demonstration that the better results can be achieved with further or addition of or at least one medication. And the concept of triple therapy, as we will discuss later, is now being introduced for the treatment of lupus nephritis. So belimumab, which is a recombinant human immunoglobulin monoclonal antibody that inhibits the B cell activator, also known as the B lymphocyte stimulating protein. This has been approved for use in non-renal lupus patients who are 5 years or older. However, patients with acute and severe lupus nephritis were excluded from the initial trials, the BLISS 52 and the BLISS 76. However, post-hoc analysis of these trials demonstrated that patients who had proteinuria at baseline had decreased proteinuria and a lower incidence of renal flares than patients who didn't receive the belimumab. So the BLISS-LN study was conducted where belimumab was added to both mycophenolate mofetil and cyclophosphamide and subsequent azathioprine regimens in patients with active lupus nephritis. At week 104, significantly more patients in the belimumab group than in the placebo group had a primary renal response, 43% versus 32%, and a complete renal response, 30 versus 20%. And the risk of renal-related events or death was lower among the patients who received belimumab than among those who received placebo. So, as we discussed previously, class 1 and class 2 lupus nephritis generally do not require immunosuppression. Class 3 and class 4 require aggressive treatment with immunosuppressive. Class 5 should also be treated in the same manner as class 3 and 4, and class 6 generally doesn't require treatment. Now, what I wanted to demonstrate here was essentially much of what we know about the management of lupus nephritis and following the patients is essentially the same. And the full guideline has not been released, but the summary is out. And the crux and the key finding and the key recommendation is the concept of triple therapy, where glucocorticoids, pulse glucose, pulse steroids is considered the first line in the triple therapy. And what has been outlined also is that the dosing can be anywhere from 250,000 to 250 milligrams to 1 gram, because there is an aggressive move to lower the dose of steroids that we expose patients to. I know many people are used to the 1 gram for 3 to 5 days, but the recommendations are going the other way. And so that's the first layer. The second layer would be either mycophenolate mofetil or mycophenolic acid derivatives. And the third layer would be either benlysta or belimumab and calcineurin inhibitors. And essentially, these are conditional guidelines, meaning you can mix and match per se as availability or clinical preference allows. You have triple therapy, you have the mycophenolic acid, and then you can essentially interchange them. Now, the significance also is that they endorse strongly the Euro lupus protocol in terms of the use of cyclophosphamide. And so, whereas we typically have two alternatives in the previous guideline, the NIH guide protocol of the monthly cyclophosphamide, most of you will know that I prefer we do in PMH, the Euro lupus cyclophosphamide regimen, which is a lower dose cyclophosphamide regimen, treating the patient every 14 days for 6 doses, lowering ultimately their exposure to cyclophosphamide overall. And so here we have, again, the concept of triple therapy as first-line therapy for lupus nephritis is going to be the new recommendation and the new standard of care. And the availability now is the issue because these medications are very, very expensive. So in our setting, I don't think to this point we have these available. The calcineurin inhibitor that we have available, I think, is tacrolimus or cyclosporin, if they are available. But generally speaking, we don't stock these medicines at this time. So herein is the significant point. There's new guidelines for a very common local disease, and we were keeping pace. But now, as a system, we have to figure out what we're going to do to meet this challenge and potentially offer our patients this type of care. Perhaps we can approach it in a staged manner or as needed, or if they're failing, etc. Okay, so this lack of response, then like we say, you can change from an alternative triple therapy, or you can escalate from dual therapy to triple therapy. So this is just talking about the specific regimens of cyclophosphamide that we talk about and the dosing of mycophenolate and mofetil. We tend to use we tend to use the 3-gram dose because the lupus nephritis in our patients is very aggressive. So lupus nephritis is one of the more devastating complications of SLE. Appropriate surveillance and management can reduce morbidity and mortality. Understanding the pathology is critical, and offering the patients the first-line therapy is now going to become our new challenge as an institution and a system. Thank you.
Thank you so much, Dr. Parker, for providing us with those updates. They're very important because a part of evidence-based practice is to be able to offer what the research shows would be most effective. And of course, we want the absolute very best for our patients. So at this time, I will take questions and any comments that you may have for Dr. Parker. Do we have any questions for Dr. Parker? While you think about any of your questions, please note that I would have just put in the chat the feedback link for this presentation. As stated earlier, this is a accredited CME, so we would like for you to attach your feedback for this presentation. It is absolutely necessary for the release of your CME credits. For those who may have missed it earlier, please ensure that you sign in with your correct name, not your first name or your last name or an abbreviation or your phone title. We do need your BMC registered name. Additionally, I would like to draw your attention to a community education event that the Department of CME is putting on this coming Saturday, that's April 12th at 3:00 p.m. at the Believers Gospel Chapel. That is on Prince Charles Drive. Some of you may have seen the flyer. If you have not, I want to encourage you to encourage your family members, encourage your church members, encourage absolutely anyone you know to attend. It will be on the topic of understanding autism, which will be presented by Dr. Saunders. A lot of people feel like, oh, well, this might not be a presentation for me. Absolutely incorrect. We all know a child. We all know someone with a child, with the information, we're able to pass it on to others. Okay, we have a question, Dr. Parker, from Dr. Taylor. Just how expensive are the new drugs? Is it because it's the IS market?
The expense of the voclosporin, at one point I think I had looked up a course of voclosporin. It was like 75,000. It's ironically the voclosporin, which is a pill, is more expensive than the Benlysta. Benlysta is as expensive as typical biologics. You're talking about a few $1,000s a month. But with the Benlysta, you're talking about a few $1,000s a month. But the regimen is with one dose, and then 14 days later another dose, and then 14 days later another dose, and then a monthly dosing if you're going to give the IV dose. So it's the cumulative dosing and the continuous dosing. You see the endpoint going out to 104 weeks. So that's 2 years of $2,000 a month after you start up at $6,000 for the first month. So a course of therapy could cost the patient, at least over the first 2 years, you're talking about 100,000. You're talking about $50, almost $100,000. Sorry, at least 50,000. First year 50,000, second year 50,000, 12,000, 24. It's 50,000. It's $50,000 for 2 years. So that's how much it would cost our system. Now, if we want to negotiate with the drug companies, we can do that. But I would put it out to the. I see that we have a lot of individuals in senior and management positions. I am currently in the process of tracking my utilization of Benlysta. So I mean of rituximab, which is roughly as expensive, to demonstrate that the use of this medication in lupus patients is life-saving and necessary. At present, the oncologists have been given a budget, but this is as good a time as any to state that as far as I am concerned, autoimmune disease must no longer be considered a rare disease and a rare phenomenon, and lupus must no longer be considered a rare disease. A lot of the primary care doctors can attest to that. Everybody knows somebody with lupus personally. I mean, I have lost a relative to lupus nephritis specifically, and it is now time to face the reality that lupus is common, and certainly is common in our population. Most of the people who encounter this condition are going to be uninsured patients. Uninsured patients in the prime of their lives. Be more specific, uninsured female patients in their childbearing years. And so it is I plan to make the case to administration that the rheumatology, we need a budget similar to the way that the oncologists need a budget. This hospital is the only place that some of these patients can go to get, the majority can go to get the life-saving and highly expensive treatments they need for not only lupus nephritis, but for the dangerous and life-threatening autoimmune manifestations. And even though we all are familiar with tragedies and loss with respect to some of the patients with lupus and some of the various autoimmune manifestations, I can state with a sense of pride, not personal pride, but institutional pride, that up until recently, we had what was necessary, and we still do, to treat the majority of patients who present with life-threatening autoimmune diseases, so much so that many of the physicians are comfortable doing it. However, we have to make this a systemic and a rational process, because it's not going to go away, and it's only going to become more common, and it can happen to anybody. And the approach now has to be in the same way that the oncologists have a budget and the oncologists have a place to treat their patients. we need that for rheumatology. Now, I'm not saying that the other subspecialties are not important, but it's my job to advocate for my patients. And I would say that we have to view, even though we view ourselves as a hospital, the hospital is the only place where many of the public and uninsured patients are able to access subspecialty care. And so we have to view ourselves in that lens. And I think we need to form some type of system whereby we account for, we can expect X amount of renal presentations of lupus nephritis in a year. We can get that information, and based on that, we can predict how much doses of Benlysta, how much doses of voclosporin, how much doses of rituximab we should have on hand, and at least make a move in that direction. And I would also suggest that as the government has significant purchasing power relative to virtually every other institution in the country, we look towards the biosimilars and sourcing medications from Europe, where biosimilars are all the rage and patients are able to access biologic care and biologic medications for much less than we get with the drug companies locally. This issue of a mandatory markup, etc. We have to start being innovative and sourcing, because it's a rights it's a rights issue, really human rights issue, where you have these medications that are available and they're just out of. It's like the government saying we can't give you chemotherapy. I'm not concerned that you don't give me all the chemotherapy, but offer me something. And so, and that's not a knock on the system as is. Like I said, I think we've been doing pretty well. But as things get more advanced, we have to be more rational. And in order to be cost effective, we can predict the utilization of these medications. And if we can meet the full requirements, at least half, and then we can have a strategy. Nephrology and rheumatology can determine based on the criteria who gets what. But we need to start budgeting for this. We had a patient in the ICU with dermatomyositis who only ended up there because we couldn't get the IVIG for 10 days. And then, of course, when he goes to ICU, it becomes an emergency, gets the medication. But we have to begin to, I would say, rheumatology is not a boutique specialty. It's not a small subspecialty anymore. And I would argue that we need a budget. That's really what my goal is, quite making the case for a budget for lupus patients, and secondarily for a budget for catastrophic presentations of autoimmune disease. That is something I would like to see before my time in this institution is done, and I think it's possible. And I think it's fair. It's fair. It's a matter of fairness. The oncologists get a lot of consideration, but it's time to now expand our minds. Everybody knows somebody with lupus, and we now need to move to a situation where we have a budget for lupus in the hospital system.
Okay, thank you, Dr. Parker. We have another question for you. Good morning. In a patient with SLE newly diagnosed, what would warrant early specialist referral?
That's a good question. I like that question. Early specialist referral. Well, what I would say is that any patient that you see with SLE, if they have, you're obligated to screen them for proteinuria. So if they have proteinuria, significant proteinuria, 3+ on the dipstick, or spot urine protein creatinine ratio of greater than 0.5, then certainly that's one indication. If you feel that the patient is very ill, meaning that they have an organ-threatening manifestation or a life-threatening manifestation, or if the patient is unable to function due to pain. Certain indications for early specialist, subspecialist referral. Now, let me state that in a, I will expand on that as I have done. And I am on the record. I have written to Dr. Francis Williams on this issue. So I'm not just saying it, but the level of support that we get in the clinic for subspecialty medicine is not acceptable. One person and one SHO does not make a service. And I have been advocating for that for years. And I have ultimately been making the case that we have to restructure the way that the clinic system runs. And we have to accept that medicine is changing. We have the body of physicians has changed for the better, and that many doctors are now qualified as specialists. And that has improved the system and improved patient care. Many of the patients who have a primary care doctor, particularly those in the family medicine program, we liaise directly because it is not feasible, obviously, for two subspecialists, two and a half, depending on how you look at it, to manage all of a patient's, all of a nation's care. And many of the people, the subspecialist, the primary care specialists are very rational about how they take care of the patient. We liaise, we talk about what has to happen for the patient, and we manage the patients together. If a patient is ill enough and they can't be accommodated in the clinic, then they should go to the hospital. But to answer your question, any incidence of lupus nephritis and any organ-threatening manifestation, and if they just can't function, if you're going to send a patient home to stay in bed and with her, then send them to the hospital. You know, I hope that answered the question.
Okay, thank you. Dr. Munnings would like to know anything on prevention of lupus, example, dietary, lifestyle.
Well, that dietary and lifestyle changes and supplementation, that is becoming all the rage. I mean, I did a presentation on holistic management of lupus nephritis, of lupus in general, last year with the 242 lupus group. To my knowledge, there is not a definitive ACR or EULA recommended diet that has been demonstrated to have improvement in objective, reproducible clinical markers for lupus nephritis or lupus in general. What I say is that there are many studies that report, for example, that the Mediterranean diet has lowered certain inflammatory markers, and that the various different diets, veganism and that type of thing can help. So what I say to patients is, I don't have a specific recommendation to you, but what I recommend is that I know sugar is anti-inflammatory, processed foods are anti-inflammatory. And so I recommend that they eliminate at least the fast foods, at least the sugars on the regular, minimize, I'm talking about. I don't necessarily recommend that they become vegans, you know. I don't necessarily recommend, they quote unquote stop drinking. I certainly would recommend that they stop smoking. But I would say to eat as healthy as you can, exercise as much as you can, um, follow the vitamin D levels. But no, I don't have a specific, not that I don't think it's important, but I just don't think it exists as yet. There's a recommendation for rheumatoid arthritis, about vegan diet or as close to vegan diet as possible. And I'm also very careful about this approach because it can often be an escapist way to patients to run away from the reality that as much trouble as there is with allopathic medicine and Western medicine, and as much as there are issues with iatrogenic issues and there's a pharmaco-industrial complex, the simple reality is nothing treats autoimmune disease better than conventional medicine at this point. And so I am careful to state, and y'all can quote me on this, you can use it. I tell patients, you didn't eat your way into this, and unfortunately, you're not going to eat your way out of it. Everything, every little bit helps, but I want them to be healthy, but don't make the mistake they're thinking that they don't need care. Because with the autoimmune disease of the lupus and the lupus nephritis, early and aggressive treatment is the hallmark of care, regardless of what you use. So you have to be careful when you're talking to a patient. Many times the patients are basically looking for a way out of conventional medicine. And so I firmly stand up for conventional medicine until I feel like that is understood. I don't go into the secondary recommendations because I think more harm is done by overemphasizing unproven strategies and leaning into community stereotypes and quite frankly into denial than this. I would say this: it's better for a patient to eat bad and take their medicine than to eat good and not take their medicine. I would bet that the patient who takes the medicine does better. Until someone can prove to me otherwise, unfortunately. So I'm not. It's a nuanced question, and it makes the patients feel better when you take them on. So I do, but I'm always careful to make it explicitly clear that there's not going to be a reasonable way out of their predicament or forward without taking the medication. I think we play a dangerous game when we facilitate too much of that. And I also warn them against drinking bush medicine. You know, one of the first things I tell them is that when they are diagnosed with lupus, somebody's going to bring you a bottle of something. You know, don't drink it. Or at least if you could drink it, take my pills first.
Okay, thank you, Dr. Parker. We have another question for you asking about the prevalence of lupus in the Bahamas.
Well, the reality of it is I don't have a specific fixed number to give you. Um, the short answer is I don't know. The less data-driven answer is it's probably more common than it is in the United States. And this is a Black population, and it's a Caribbean population, and it's a small population. And without being, saying uncomfortable things, when you have small population, you have gene amplification. So unfortunately, lupus is common. The critical thing for any doctor to take away is when in fellowship, there are certain things that we would comfortably say it's not the lupus. We would say it's not the lupus, but um, I've learned over here that many times it is the lupus. So our autoimmune disease is worse. I would say Afro-Caribbean is worse than Afro-American. So it's common. That's why I say it's not rare, you know.
Okay, we have another question almost along the same line. There seems to be an increase in autoimmune diseases globally, the Bahamas included. What is your opinion, maybe some of the causative factors?
I guess that's again another question you have to look at. Is it until you have data and reproducible trials and that surveys and until we have that kind of workforce to generate that kind of information, we're just speculating. The reality of it is the awareness of autoimmune disease has increased tremendously to the point where now we have, when we just saw it in clinic the other day, we have many referrals of patients to rheumatology clinic with negative ANAs that are interpreted as positive, or positive ANAs that are not significant. And that's not necessarily a bad thing, because when you over refer, you're definitely going to get, that means we're not going to miss any cases. So I have no problem seeing those cases, and I don't have a problem with the physicians being concerned and sending the patients for screening, because if you under-screen, you'll miss. And so I don't have I'm still not going to move from the position that it's increased awareness of autoimmune disease and increased appreciation for the the mechanism of autoimmunity, and how it underlies conditions in a way that we did not appreciate before, that is increasing. For example, there's an autoimmune component to cardiovascular disease that was not appreciated before. And it's just a deeper understanding of how conditions work and an increased awareness of the conditions. I think that is driving a lot of what is happening. The cancer data, the cancer doctors may have, I think they collect better data than we do, quite frankly. So they may be able to tell you if there's been a change. I'm not saying there hasn't been. But in terms of what do I think? I mean, I don't like to spook or speculate, but we eat a lot of processed foods, myself included, and we live in a more toxic milieu. I don't doubt that. The car exhaust, the pollution, the chemicals, and so we have to face the reality that we've made our world more dangerous in order to make it more comfortable. And so I'm not going to point the finger at one thing, but I will accept that we live in a more toxic milieu. And certainly the global consciousness to reduce that toxicity is a positive thing, so long as we're not irrational about it. And as physicians, we can't afford to be irrational, and we can't afford to lead our patients down the garden paths without evidence or proof.
Good morning.
Good morning.
Good morning, Dr. Thompson.
Dr. Parker,
You can
excellent
go ahead.
presentation. Excellent presentation. Thank you. I understand that you may not know the prevalence, but are you able to say on average how many persons you've seen with lupus since you've been back, please, in your practice or even at PMH? Thank you.
Oh, I mean, it's a good question. I probably could, well, let us, that's a good question. Myself and Dr. Avro tried to address a similar issue. And I think going forward, at least with respect to the public side, the paper record system doesn't facilitate that. And we tried, because we went back and we literally tried to do a study, and we were able to succeed to a certain degree. But until we improve our record keeping, so that we can conduct these type of studies on a keyboard by referencing patients' admission diagnoses or clinic diagnoses, medical records by computer, or that is where I think we will end up being able to answer these questions. Unfortunately, the record keeping system publicly, and this is just a general thing, it's just not good enough to support it. Privately, it's possible. I would have to go back to all of my admissions since I started using EMR and do that. So I mean, it's a doable thing. So I could generate a numerator, but I don't know that how meaningful that would be in terms of the denominator, because I don't see all the patients. I think the public system would be a more meaningful number. And I mean, it's possible to generate. We'd have to figure out how we want to do that, because that would require, you're talking about confidentiality issues, and everybody can get together and get it done, but it requires a lot of effort, realistically speaking. But what I can tell you is that It's common. You know, we look at our. I mean, we have to consider the questions you're asking. Really get to the point. The way that we look at the hospital system and the way that we are staffing the system and the way that we're running the system now has to really be addressed, because what you have is a lot of seniority, but we don't have we're going to have to face how we're going to deal with the workload associated with all aspects of delivering care, from inpatient to clinic care to research to all of that. I mean, that people often delivered mandates, and you're delivering a mandate to one man, you know, and it's just not feasible. We have to restaff the hospital, and we have to restaff the public system in such a manner that addresses the needs of the country, if that's what we wanted to do. I mean, I take the position that we are all public patients. Private care is a convenience and somewhat of an illusion, to be honest. At the end of the day, how many times have we seen it? The big wigs flying on high, and they end right up in PMH. As will you or I if you go through your little $1 million. So the reality of it is we have to look at the public system as our public system. It's the real public system in the country. And it's the real medical system. The private system is where people make their money, but at the end of the day, the public system is there for everybody. So if you want to make these demands of the public system, I have no problem with that. But we have to now relook at the system. We have generated the expertise. Now we have to and we've drained the junior ranks, meaning that we've allowed and facilitated the actualization of the physicians. So now we have to revisit how we man the system, because the truth of the matter is, one senior doctor sitting in the clinic is not a service. And like I say, I'm on paper making that point, and I put a limit to how much patients can be referred to me, and I say publicly that if they're going to refer any more, I'm not going to sit. I'm tired of sitting in the clinic 4 or 5, 6 o'clock, seeing patients by myself when the nurses have gone and everybody else is gone, just me and the patient. I'm not going to do that to myself, because it's not rational, it's not fair, and it's unnecessary. And what I've said is, if anybody wants to put more patients on my list, they can come see the patients with me, or the patients wait. Because what is going on in the hospital, the junior doctors know, is unacceptable, and it can't continue. And I don't say that to be mean or spiteful, it's just reality. The service is crashing. The quality of care is not sustainable. It's not getting better. It's getting worse. And frankly speaking, the care in the public ward is better than used up. Anybody more questions?
Okay, thank you. Thank you, Dr. Parker. We definitely been updated with valuable information regarding the management of lupus nephritis. I hope that we all can take away this information and be very mindful when we encounter these patients. Our ultimate goal is to ensure the very best care for the patients that we serve. We look forward to having you at our CME at the end of the month. That would be April 25th. So look out for that notice. And once again, remember the community education event this Saturday, April 12th, 3:00 p.m., Believers Bible Chapel. Have a great day, everyone.